And I just gotta move a few things around here. Okay, is that looking okay on people's?
Perfect. Looks great.
Okay, great. So this is a 3-hour talk, yeah, in 20 minutes. So we'll do the best we can and try and have it a little bit interactive here. We have a few polls and some questions as we go. And I know the Echo home team will kind of rein me in or steer me straight if I go adrift a little bit. So nice to meet everyone here. Dallas, I'm a geriatric psychiatrist at the University of Calgary. Work quite closely with the CCSMH. Happy to be here today. And we're going to talk a little bit about screening assessment, a bit about treatment of dementia. And there we go. So here's my faculty disclosure. I'm going to brush over that quickly here. This program has received support, and I'm sorry, I've got the wrong support slide up from our last presentation. This is actually from the Public Health Agency of Canada. The RBC Foundation supported a previous ECHO. So my apologies for that. And we're very grateful for Public Health Agency of Canada support. Great, and try our best here to have peer-reviewed evidence-based recommendations throughout the presentation. So I'm going to briefly touch on who should be assessed for possible dementia or cognitive impairment, outline some of the key steps to include, and some of the key supports, non-pharmacological and pharmacological treatments options for people recently diagnosed with dementia. So we're going to go through this quickly. There's a lot of reference material here in the slide deck that you can all have afterwards, so I won't spend too much time on all the slides. But just to talk briefly, all this recommendations, we've actually got pretty good dementia guidelines, and here's a bit of a plug. We're actually developing new guidelines for behaviors in dementia. So we have some surveys that we'd really like your opinion on that we'll put up at the end. But much of what I'm going to be talking about today is based on our Canadian guidelines for dementia. And these have been going on for some time, since 1999 up to 2019. They cover a whole range of topics. One thing with guidelines is there's a lot of information that can go on guidelines. And so sometimes it's a little hard to weed through how do you put this into practice or make this practical. So we had a research project looking at sort of a stepwise approach to the assessment and management of dementia. And I would say there isn't a right or wrong way to assess and diagnose dementia, but there are some key processes and things you should go through. And so these algorithms you see here, we can make available. They're just a way to kind of guide you through different steps and decision points in the assessment process. Again, it's not to say this is the only way to do it, but it's one way that is kind of hopefully logical and captures the key points. So there's one on evaluation. There's a separate one on initial management. Okay, so why do we assess cognition in the elderly or older adults or anyone? Well, there's a number of reasons to do this. Obviously, people sometimes present with cognitive complaints. We need to establish a diagnosis, like whether there is dementia there, to think about how other conditions might affect cognition, like medications, to kind of evaluate people over time. We use it as a way to communicate with each other. I think probably most importantly, it's an important part of how to promote safety and autonomy by understanding someone's strengths and limitations. And in terms of the dementia, we know that this is, it's an increasing problem for society. So right now there's about 600,000 people with dementia in Canada. This is from the Landmark study by the Alzheimer's Society. So it's like 125,000 new people each year diagnosed with dementia. And we're expected to have over 1 million people with dementia by 2030. So it's already pretty common in Canada, and it's going to be more common as time goes on. So I might ask, if we still do this in ECHO, just a question for participants here. People want to put in the chat maybe some of the risk factors for dementia that they know of. or things that you might want to consider when evaluating for someone who might be at risk for dementia. And just put that into the chat there for a few minutes. Yeah. Great.
I don't know if you can see these, Dallas. Sometimes it's hard when you're
they're rolling by pretty fast. Substance use, head injuries, substance use.
I know.
Good work, everyone.
Fast and furious.
Yeah, that's great. All right. It's okay if we move on. We got lots of great feedback there. Good. So absolutely, yeah. So many of these came up in the chat. So here are some things that on the top that can increase the risk of dementia. Brain injury, that was one that was brought up. Pretty much all your cardiovascular risk factors, things that can be protective or decrease your risk of dementia, like education, physical activity, cognitive training, all these different things. So it's a variety of different things that can contribute to increased risk of dementia. And this is important. I think, where a lot of research literature is really developed recently is about how much of dementia may be preventable. So up to 40% of dementia might be preventable through preventing things like head injuries, better management of cardiovascular disease. And we know actually that people who are seniors now, they're actually less likely to get dementia than people from a generation ago, because these risk factors are becoming less common or better managed in our population. So that's encouraging. And in terms of dementia risk reduction, these are the things that have been shown fairly good evidence to reduce the risk of dementia. So a Mediterranean diet, for example, moderate physical exercise, hearing loss, that came up as a risk factor, sleep apnea, cognitive training or cognitive activities, social engagement, reducing medications, and I would say substances like alcohol, cannabis, that can impact on cognitive impairment, and to treat risk factors like hypertension and stroke. So I think we're going to maybe pull up our first poll here, if that's okay. And we'll get people to respond to the poll if that's possible here. Great, so we have a poll up now asking which of the following is true regarding the assessment of dementia. We've got 4 options here that you can select one of the options. We'll see what people. And our options are: all adults should be screened for dementia, neuroimaging like a CAT scan or MRI should be completed on everyone, caregiver history should include standardized tools, most people with dementia prefer not to know their diagnosis. That's great. It's coming down to the wire. It's neck and neck. Do we screen? Do we give caregivers a questionnaire? All right. So maybe we'll stop the poll there. And it looks like caregiver history. Good. And the correct answer, I don't know if it pops up here, if there's anything magical we need to do. But the correct answer was actually C, that the caregiver history should include the use of some standardized assessments or consider the use of that. We'll talk about the other considerations or options here too. Great. So in terms of what's often referred to now as case finding or assessing people who might be at risk of a condition, it's really recommended that we don't screen asymptomatic individuals. Like we don't do cognitive tests on everyone age 65 and older. It's recommended that we screen using an interview, testing, and review with family people who have cognitive complaints, functional change, or new onset of psychiatric disorders late in life, because these populations may be at an elevated risk of having underlying dementia. For people who have high-risk conditions like our advanced age, stroke, Parkinson's, head injury, you can ask people if they've noticed any cognitive concerns, because the underlying risk of dementia or prevalence can be high in those populations. It's really recommended to use validated tests like a MoCA or mini mental or other tool to assess cognition, and to also include a caregiver tool like an AD8 or IQ code. And we'll talk a little bit about those, but that was the correct option answer to the poll about using a validated caregiver reported tool, which can be very helpful in assessment. And what are some of the tests that can be used in screening for cognitive changes? Talk a little bit about the mini mental, most of us may be familiar with, the Montreal Cognitive Assessment, briefly about the St. Louis University Mental Status Exam, and a caregiver report called the AD8. So for most people, probably somewhat familiar with the mini mental. It's widely used. Out of 30 points, has 12 items, requires little training. Age and education can introduce bias, and it's also copyrighted. So some places, ideally you should have a copyright permission to use it, although there's often copies of MMSEs floating around that people use in their offices. It has somewhat lower sensitivity and specificity, like its accuracy isn't as good as some other options potentially. So it does have some limitations, although it's fairly well known. And this slide just shows in the bottom left, you see if someone was relatively young age with higher education, you see their normal score might be a 28, whereas in the top right corner, someone who's over age 85 with little education may have a normal score of 19. So you have to take into account age and education when interpreting the mini mental and whether it may be abnormal or not. MoCA, it's commonly used tool. Training is now recommended or required for using the MoCA, which can pose some limitations on who can use and administer it. It does tend to be a bit more accurate than the mini mental, although it does take a little bit longer to administer. The MoCA is particularly well suited to detecting mild cognitive impairment, where the mini mental is not so good at that. The MoCA is a bit better in terms of a screening tool to assess mild cognitive impairment. It's also prone, though, to some effects with age and education, so that needs to be taken into account. So I want to share a neat little resource. This is Canadian content available at qco.org. That's a quotient of cognition. And it's actually a little online tool that you can plug in someone's age, education, and MoCA or mini mental status exam score. And it'll tell you where that person's score is compared to where they should be for their age, education, and their score. And so I think this is an example of a helpful tool that can help a little bit with interpretation. I sometimes use that now, where I've kind of got a gut sense sometimes of what would be a normal score for an individual. But this is based on large sort of epidemiological studies where they've done these tests, and I've also looked at whether people have dementia or not. And so this is a neat tool that anyone can use, and it's based out of Quebec actually, so it's Canadian content. So a good resource. And the slums, this is one we use in Alberta now, because the MoCA with the training requirements has made that difficult to use in a lot of our care settings. So we use the slums, which is a good tool. You can download this off the internet. If you're familiar with the MoCA, the correlation between a slum score and a MoCA score are pretty similar, actually, when they've done studies. They kind of line up. So a 20 on a MoCA is kind of about a 20 on a slums. There are some adaptations. It's an American test. So in Canada, we use the province instead of state, and we use the city Toronto instead of Chicago as some of the prompts in the testing. But this is another tool that can be used. And in terms of informant reports, this is one I really like. This is like a questionnaire you can hand to a family member and ask them to check off yes or no if they've noticed changes in someone's cognition over time. And I think this is a really good way to get family history. And it's also a good way for family to provide some feedback, but sometimes they don't like to share verbally in front of the person who's having memory problems. So this is a way to get that information, but also sometimes that can be a bit awkward where a family doesn't feel comfortable volunteering all the changes that they've seen. So I really like the AD8. And again, this is something you can download and use off the internet. Okay, so when you're establishing some cognitive changes, it's important to kind of work through what might be causing these, some of which may be normal aging, mild cognitive impairment or dementia. We'll talk about that, but also secondary causes like delirium, medications, or medical conditions. And in terms of a differential diagnosis, or the main things that can sort of look like dementia or cause cognitive impairment would be dementia is one, which we're talking about here, but delirium, where typically there's more of an abrupt onset of cognitive changes, often a fluctuating course, and it's usually tied to a medical condition like an infection, for example, or depression, where people may have more difficulty concentrating or participating in testing, along with changes in mood. So these are the kind of main conditions you may want to rule out in people who are presenting with cognitive changes before concluding that it's due to dementia. So next question here for people to throw in the chat is, what are some of the things you'd want to ask a patient or a caregiver on history when assessing someone for dementia? So how would you go through a history? What sort of information would you like to know from them? And we'll get people to put this in the chat. Good. Yeah. That's great. There's lots of great answers there. Okay. They're still rolling in. I'm going to move to the next slide though. So here's some of the things to kind of touch on. I think most of these are captured in the chat. You know, what was the onset and what's been the course of these cognitive changes? You want to ask questions around different areas of thinking like memory and language, things like depression, medication and substance use. Education came up a number of times. Then as we talked about risk factors and high-risk populations, you know, all those medical conditions, particularly those that directly affect the brain, be important to ask about. And in terms of investigations, in addition to your history, it's recommended everyone have a general physical, including vitals, and a screening neurological exam, particularly to look at signs of stroke or Parkinsonism. There should be some blood work for all individuals. This is the recommended blood work. This is a recommendation that's changed a little bit over time, but it's now recommended that everyone who's being evaluated for dementia at least have some neuroimaging completed. And definitely, if any of these sub-bullets are listed, like sort of unusual features or rapid progression. But it's really recommended now everyone have a CAT scan or preferably an MRI to evaluate for cognitive, as part of the workup for their cognitive difficulties. And then as part of that assessment, you also want to do a detailed functional assessment. And I like to use a structured questionnaire for this as well. So the one I have up here is called the Functional Activities Questionnaire, the FAQ. which this is again for a caregiver to complete, and they provide a score of 0 if there's no impairment on things like paying bills, up to 3 if they're completely dependent. And this is also a very nice way to get like a detailed history from a caregiver and understand some strengths and weaknesses that people might have, associated with some of these cognitive changes. And then the diagnosis of dementia relies on this history that we've gone through, the physical exam, some testing, the assessment of functioning, which we touched on, and then sometimes you need longitudinal testing to establish a diagnosis. And these are the criteria for dementia, or what's called major neurocognitive disorder, but it's basically evidence of cognitive decline in one or more areas of cognition that is noticeable by the individual and an informant, or is a change for the individual noticeable by an informant, and accompanied by a decline in functioning that is also demonstrating some abnormalities on cognitive testing beyond what you would expect with aging. And it's not due to another condition. Great. Well, I think I'm probably at close to time here, Megan. We can stop there, or we could go through a little bit of treatment.
Yeah, I think that's okay. We've had a few questions in the chat that I wanted to make sure that we get. And one was about the relationship between hearing loss and dementia. Would you be able to speak to that a little bit?
Yeah, a little bit. There is a pretty well-established link between hearing loss and dementia. So significant hearing loss is associated with about a 2-fold increased risk of cognitive impairment. The exact mechanism sort of linking the two is unclear. However, there's also some evidence that correcting hearing loss may help restore some cognitive functioning, or sort of reduce the risk of dementia associated with hearing loss. So is very important. And I think just from a kind of like a logical standpoint, if you're really struggling and mentally taking a lot of energy to take in information, to hear information, you can imagine that's taking away from your brain's ability to store information or to pay attention to other things. So I think it's just, there's probably some direct effects on memory, but also just like the mental strain of not being able to hear can really aggravate memory problems or thinking difficulties.
And then we had a couple questions about some of the screening tools. So one was, do you see the slums used more widely because of MoCA copyright?
Yeah, in Alberta, they've I would say in Alberta, they outlawed, the MoCA on Alberta Health Services program. So we all switched to the slums. Interestingly, it looks like there's going to be some arrangements that are going to be made to either provide the training or waive the training requirements for use in healthcare settings. So we may be able to go back to using the MoCA. And I don't think the intention with the training was to get people to stop using it. I think there was, concerns about how and who was using it and how it was being interpreted. So hopefully we get to go back, because it would be my preferred brief screening tool. I still use it whenever I can in my own clinical practice.
Yeah. Okay. There was a question about cutoff scores for screening and what is normal or what are the cutoffs for normal, MCI, and dementia, but then some questions about changing the interpretation for visual impairment. So, and you had mentioned about years of education. So I wanted to bring that one to your attention too. Yeah,
that's a good, and that's, I think, a tool potentially like the QCO that I put up is a good one, because that cutoff really varies depending on the number you use for the cutoff and then the person that you're applying it to. And so there isn't a single good cutoff on any screening test, you really have to sort of take into account the education and age. And so the MOCA, for example, uses a cutoff of like less than 26 or equal to 26 to indicate, anything above that is, maybe normal. But then it gets really murky, below 26, does that mean someone has dementia or MCI? Of course, most people below 26 don't. And so how do you use that cutoff to distinguish between different conditions is hard. So I like the idea of, if you don't have a lot of experience using these tools, to become familiar with how it can change with education and age, or potentially use tools like the QCO to get a sense of where your particular patient falls compared to other people in a similar circumstance. And I forgot the second question, which was
I think that was it. It was like cutoff scores and then interpretation for.
Okay.
I think you hit on it. And then there are some. I'm going to try to group questions because we are getting a fair number, but about cultural specificity, and is this testing culturally specific?
Yeah, I think there's cultural biases for a lot of our tests. There definitely are translative and validated versions of the MOCA that need to be taken into consideration. So that's one way. If you have someone who could translate a test like a MOCA, there's other tests that are a little less biased by education and culture. So the RUDAS, R-U-D-A-S, I think it's a Roland University Dementia Assessment Screen. That's one I would sometimes use if there's like a real concern about language education, cultural bias. And it tends to be a bit more generic, asking people to remember common shopping items, pointing to body parts, generic kind of safety scenarios, those sorts of things. So that's an example of a tool I sometimes use when that's more of a concern.
And we did have a question specifically about the RUDAS, so that was very timely. Are there any screening tools that are used effectively with individuals who have an intellectual or developmental disability, or who maybe would have never been able to respond to the questions used in like the MOCA or MMSE?
Yeah, I mean, I would say that's a difficult one, and I'd be curious to get other people's thoughts on this. I think, one of the key things there is really the functional change. And that's often what I really pay attention to. If there's a question about has someone developed, someone who may have a developmental disability, developed a dementia, and looking at the change, well, they used to be able to manage their medications or, remember to dress themselves properly. And over the last 6 months, we've noticed these sorts of changes. So I think the functional change, taking into consideration what their baseline was, is very important to kind of distinguish, because you don't often have a good baseline cognitive test to be able to tell, well, maybe the scores would have been their score 5 years ago, and knowing whether that's changed or not.
Thank you. And we'll give you one more before we move over to the case discussions. And it says, what is your take on performing standardized testing on delirious patients?
Yeah, it's not that useful. I would say, it may tell you, and it's potentially, can be quite misleading if someone's in hospital delirious, they have a MOCA done that's 13 or something, and then people are making decisions or interpreting what their needs are going to be in the community based on or whether they can drive safely after discharge based on a score that reflects their cognition when they were quite sick. So I think it's often good to have some screening, but to also keep in mind that is unlike a typical assessment of dementia, that's probably not their baseline, right? It may change a lot. It may change a lot over a short period of time. And so really to plan to have, pretty careful follow-up and reassessment of that cognition, and not rely on that point when someone's delirious to certainly not to make a diagnosis of a dementia until the delirium is, has resolved as much as it can.
Thanks, Dallas. And that was a really nice segue, because next week's session is all about delirium. So we can do a bit of a deeper dive and talk about some things that would be helpful assessment and treatment strategies. So we will, I'm actually going to share the slides for our first case presentation.